The sound that comes through a cochlear implant is pretty crude compared to what we can hear with normal hearing. Remember that with a normal functioning inner ear, we can hear a huge range of different pitches. But with a cochlear implant, there's a finite number of electrical contacts that are placed in the ear that are then driving those auditory fibers to fire. The number of contacts you have is directly related to how successful the implant may be. The very first cochlear implants only had one electrode, and they weren't too successful because all the people could hear was kind of the rise and the fall of speech. They couldn't hear the detail in speech. They couldn't hear enough detail to make sense of what was being said. So they got presence versus absence of sound, but they didn't get good speech understanding. So these are some examples of simulations of a cochlear implant, of different numbers of channels inside the inner ear, and then what the actual signal was. So here, I want you to listen to these sounds and see if you can identify any words in this sentence. And again, this is just a simulation of what a cochlear implant would sound like. We can never truly know what an implant sounds like because it goes into somebody's ear, and everyone's ear is a little different. So how much hearing loss you have, how many surviving fibers you have, how long you had hearing loss, where the electrode is sitting inside the inner ear, all those variables lead to a lot of heterogeneity in what people are actually hearing. So these are simulations. They're our best theoretical understanding of what's coming through the implant. So here's one channel of stimulation. I'll do it again, a little bit louder. Whoops. Could you hear any words? No, so you could hear the rise and fall of speech. I heard wah, 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 wah. Here's the original sentence.
The boy did a handstand.
Okay, I can hear that. So the wah, 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 wah. The boy did a handstand. Here's two channels, we hope. About the same, so I couldn't really hear much there. Here's the original.
The silly boy is hiding.
Never would have got it. Here's four channels. Could anybody hear any words? It's more intelligible though, hey? Like, even though you couldn't understand it, you could hear an improvement in the intelligibility of the sound. I heard the sentence, but I've also listened to these a gazillion times. I think it's the dog growled at the neighbors.
The dog growled at the neighbors.
Here's six channels. Yeah, the tree fell on the house, that's right.
A tree fell on the house.
And here's eight channels. The husband brought her flowers, yep.
Her husband brought some flowers.
Yeah. So at four channels, I could hear it, but I've got some experience with synthesized speech. But I think you could also appreciate that it was starting to sound more intelligible. What we've learned about cochlear implants is that you need at least four channels for speech to be intelligible. And then the more channels you have, the easier it is. Our problem is that once we get more than 8 channels into the inner ear, the performance starts to plateau. It's likely because we're putting electrical current into a fluid-filled system. The inner ear is filled with fluid. And we've now got very small bits of electricity going through there. It's not a lot of electricity. It's not like you get a shock. You would never even feel it. But it's enough electricity to drive a neuron to fire. And there's enough electricity that it can spread around. Remember that electricity in fluid is being conducted all over the place. So what happens after you get more than 8 contacts in there is that all the electricity is kind of moving around and it distorts the signal. If we could somehow make the contacts more specific or only stimulate this one region and not spread around, that would improve how many contacts we could get in there, and that would improve overall performance. The most recent work to do this is to use a high-rate laser beam to drive those neurons to fire. So instead of using electricity, which spreads around, use a high-rate laser beam at low levels so it doesn't burn the tissue, and use that to drive the neurons to fire. And that way, we might be able to get more contacts in and get more intelligibility out. Still, the reason that cochlear implants are successful now is that we're implanting them into people that already have a mental representation of speech. So they're people that lost their hearing in life. So even with 4, 6, 8 channels, you could hear it because you have some knowledge about spoken language. If you did not have any knowledge about spoken language, you wouldn't be able to do this task because it wouldn't be meaningful to you. So implants are successful because people are bringing their own experiences to the sound that they're now getting. It's not perfect, but it's enough that they can pick out bits and pieces, and their brains can fill in the gaps. So you can use your knowledge about language, your vocabulary, your world experience to help add to the contextual value of what's being said. The very first implant candidates were adults that lost their hearing in life. And when they were successful, we started to implant children who were deaf. The very first children who were implanted were older children and the very deafest children. And that was done because we weren't really sure how they were going to work out. So we wanted to implant them in children who could tell us what they were hearing, as opposed to a very young child who doesn't have any language and can't say what they're hearing. And we also wanted to implant them in the deafest children because we didn't want to sacrifice any usable hearing that they may have. So even if they had just a little bit of hearing, then we wouldn't want to compromise that by putting an implant in there. So the first implanted children were the older children and the deafest children. In hindsight, that was absolutely the worst decision to make because these children had already passed the critical period for learning how to process sound through their ears. The current guidelines for implanting children are to implant children at very young ages. And a lot of this data was collected by a group from Johns Hopkins looking at the age of implantation and how successful those children were. So I'm going to show you some results from a study that's pretty important in our field. And it's important because this was a large group of children, and it was published in a very mainstream journal, the Journal of the American Medical Association. In this study, there were 188 children from centers across the US. That's also important from a scientific perspective because multi-center studies help us know that we can generalize the outcomes to a broader population. These were children who were all implanted prior to 5 years of age, and they were compared to 97 children who had normal hearing. The outcome was performance on a language scale called the Reinel Developmental Language Scale. In addition, all these children scored in the normal range on the Bailey Scale of Infant Development and the Leiter Performance Scale. That means that they were all developing on a normal trajectory other than the fact that they had hearing loss. So cognitively, they weren't impaired. They all had normal developmental function. This graph shows us their comprehension scores, so how well they could understand speech. And what you see are 3 panes, a pane with yellow, blue, and with green. The children in the yellow pane were implanted before 18 months of age. The children in the blue pane were implanted between 18 and 36 months of age, and the children in the green pane were implanted after 36 months of age. The children with normal hearing are shown in the black marks here. What you see is that for each pane, there are individual lines. That's showing each child that was in the study and their trajectory of performance with their implant after implantation. So these children who were implanted youngest, we see that the start of their lines are all down here at a very low point because they were implanted the youngest. These children, their lines don't start until here because they were implanted older. So where their line starts is when they entered the study, their age at which they entered the study. What you see is a lot of variability. So some children perform really poor, and some children perform very well. And that is true for each pane. The amount of variability, however, is much greater for the children who were implanted at the older ages, meaning that the outcomes were more heterogeneous when children were implanted at an older age. What you'll also notice is the mean line right here. So this is the average trajectory performance for each age group. And you can see that for the youngest implanted children, that line is the steepest. So if you look at this line compared to this line is steeper, meaning that children are getting better faster. That's a really important finding because we want children with hearing loss who have chosen the spoken language communication route to be able to function using spoken language fluently and proficiently by the time they get to school age. So if children implanted younger get better faster, then it's more likely that they can be mainstreamed by the time they reach school. This finding was true for the way that children could understand speech in their comprehension scores, and it was also true in their expressive scores. So what they were putting out, what spoken language utterances they were making. So we see a steeper acquisition of language for the youngest implanted children compared to the older implanted children. So these data are huge in our field because they demonstrate really well that if you're going to implant a deaf child with a cochlear implant, you need to do it at an early age. If you wait until a child is older, you're likely going to miss your opportunity for maximizing performance. There are other data that show us if we implant a child over 7 years of age, that brain is already so reorganized that it can never make use of auditory information. So those children tend to be non-users. So if you're going to implant young children, we need to do it at an early age. All right, this is an interview of a mom and a child who had a cochlear implant. And I want you to pay particular attention to the child's language and her speech. And remember that 30 years ago, this child likely would not be able to speak at all.
The first sound I heard was probably
And then after all the beeps.
and then after all the beeps, I heard you.
I love you.
I love you. What did you first think when you learned I was deaf?
That's a good question. So actually, your mom and daddy, we were very excited.
Really?
Yeah, do you know why?
Why?
Well, we took you home after you were born. You were struggling to learn how to breathe and walk and talk. And Mommy and Daddy had lots of people that used to come over to our house, like occupational therapists and physical therapists and speech and language pathologists and feeding therapists. And when you were 8 months old, you passed a hearing test. And so we thought, okay, so she can hear, but something else is wrong. And so for 10 months, we didn't know what else was wrong until we took a second hearing test. And do you know your audiologist, Erin? Do you remember it's Erin? She was there with us, and then she sedated you and gave you a hearing test. She put you to sleep and gave you a hearing test, and she said, you know what? Zoe is profoundly deaf in both of her ears.
What does profoundly mean?
That means that you couldn't hear anything.
Not even a sound?
Not even a sound.
What are the other types of deaf?
There's mild, moderate, severe, I think, and then profoundly, which is no sounds.
Okay.
And that was you. And then we were actually relieved because we thought maybe there was something else going on.
Okay.
So we were pretty happy.
Okay.
Yeah. Because we knew there was something we could do about that.
Okay. So what strikes me there is the young girl's efficiency and proficiency with spoken language and her articulation. If we didn't know that she had a cochlear implant, I wouldn't identify her as having hearing loss. I can't hear deaf speech in her voice. It doesn't sound like it's hearing impaired to me, which is huge and life-changing. And it's an important technology for children who have hearing loss because children with hearing loss are often born into hearing families. 97% of deaf children have hearing parents. They don't have deaf parents. That's an important statistic because children and parents need to share a language. Not only are the parents their primary language model for their children, but there are huge sociocultural implications of not having the same language as your child. That child can then no longer communicate with their uncles, their grandparents, their aunts and uncles. So children and families need to share a language. Hearing parents could learn sign language, but data shows us that only about 17% of hearing parents who have deaf children actually become fluent in sign language. So there's this huge disconnect where children who are born deaf and remain manual communicators don't share language with their extended family. And that has implications for their own development. Cochlear implants provide an opportunity for deaf children to have hearing and share a language with their parents, which I think is critical. Okay. So we've talked about clinical trials for drugs to remediate hearing loss, hearing aids we've touched on, and we've also touched on cochlear implants. The last form of intervention that I want to share with you are adjustments to the speaking style of the speaker and the environment. The way that a person talks has huge impact on how well that message can be understood. And as we were saying before, the rate of production has a huge influence on comprehension. There is a speaking style that's called clear speech, in which speakers are instructed to slow their rate and pause in natural places. And by doing so, you do a couple of really important things. One is you slow down your productions so that it gives the person who has hearing loss more time to process sound. Remember that people with hearing loss are likely listening through a hearing aid or a cochlear implant, and that the sound is not perfect. It's likely degraded. And as such, they need more time to process and make sense of that signal in order to decode it. So by slowing down our rate, we give people with hearing loss more time to process sound. In addition, if we slow down, we tend to elongate our words. And as we elongate our words, we make that sound more salient. We make it richer. So clear speech, when produced correctly, elongates vowels, creates longer target word durations, and makes sounds more salient. What I love about this technique is that you can all do it. You can do it with your grandparents or your friends or family who have hearing loss, and you will see an immediate benefit in how well they can understand you. My grandmothers both lived to be 99, and when I would pick up the phone to call them, I would forget to slow down my rate. And I would just launch into a conversation and say, "Hi, Grandma, how are you?" And the response would always be, "Who is this?" And as soon as I would slow down my rate, they would be able to understand me almost perfectly. Producing clear speech also has benefits for people who don't have hearing loss but who are non-native speakers of English. Again, people who are non-native speakers of English need more time to process sound. And as you slow it down, you give them time, and you also make the signal more salient. It gives them more information to hold on to process and decode. So it's important for people that have hearing loss, important for people who are non-native speakers, important for young children who have immature auditory systems, and important for older adults who need more processing time. So here are a couple examples of producing clear speech. In the first example, this is just regular conversational speech like I'm producing right now. We hope. Let's try. Oh, my computer is very mad at me. I got the spinning circle of death. Well, let me produce it for you. Conversational utterances would sound something like, he looked at the cheese. Whereas a clear speech production would be, he looked at the cheese. That sounded cheesy the way I said it. The recording is much better than what I just did. But the point is that you want to pause in a natural place. So he looked at the cheese. You wouldn't want to pause in an unnatural place, like after the word he. You wouldn't want to say, he looked at the cheese. You'd want to pause in some sort of natural spot. And then by elongating the utterance, the target word being cheese, you make that space larger and, as I said before, more salient. Thanks, Tim. So this is a nice thing to do because, as I said before, you can all do it. You don't need any sort of fancy technology. It's something that we can all do to improve communication with our communication partners. Even for folks that are normal hearing, if you're out in a loud bar and the person next to you is having a hard time understanding what you're saying, just simply slow down and you'll see that their intelligibility and their understanding likely goes up. I can feel my whole body relax when somebody slows down. It just makes it a lot more salient. All right, so this was good timing because we are at the end of this lecture anyway. So let's open this up to questions. And any questions you have about hearing, hearing loss, hearing aids, drug trials, cochlear implants? Yes?
When they do drilling for the cochlear implant, how do they find that perfect spot?
Yeah. Okay.
He looked at the cheese. He looked at the cheese.
There you go. Okay. Thank you. Excellent. Good question. So how do they know where they are? Their surgeons are really skilled at identifying landmarks along that whole pathway. They know the anatomy so well that they, even though it may look like a blur of bone to us, they can see subtle changes in the density and the structure of the bone that they know exactly where they are. They can even identify when they're getting close to really important structures like the facial nerve or the auditory nerve. Typically, the patient has electrodes placed on their head so that when you get close to those nerves, it starts to beep really loudly to you. And then you move away from that spot. Yeah. Other questions? Yes, sorry.
In that one graph where it was noting hearing loss in different age groups, it's like the age group from 70 to 80 had the most profound hearing loss. Like, why do you think that is?
So that graph was showing us performance on speech perception tests for different ages. Yep, so those people likely all had the same level of hearing loss. The amount of severity of the loss was probably the same. What was different was how well they could process sound.
Well, why do you think the age group 80 was performing better?
Yep, for sure. So what we know about older adults is that they have decreases in auditory function, not only because of what's going on in the cochlea, but also what's happening higher up. So we see a loss of neural transmission and a loss of speed of processing. So older adults tend to have more central effects of hearing loss compared to younger adults. So that's why we see those age differences. Yeah.
So when people are getting tested, like for the sentences and stuff, do they get to look at the speaker to like read their mouths, or is it like strictly hearing?
Good question. So the question was, when people are doing these tests, is it auditory only, or is it auditory and visual, right? And I should have made that clear. These tests were all done in the auditory only condition, so they weren't able to see the person's face. You could argue the benefits and the disadvantages of that. The benefit is that we're just isolating the hearing system, and so I can truly know how well can you hear without adding on some complexities about how well can you hear and see. But the flip side is that we don't communicate like this, we communicate like this. And so to get a really good ecologically valid measure of human spoken language communication, it should be done in the auditory visual condition. So typically in a large cochlear implant program, we would do tests in the auditory only condition and then the auditory and the visual condition. So we could see how much is added by adding line of sight.
And is that statistically like much different?
Always. Yeah, adding vision always makes things a lot better. And you'd be amazed at how well some people with hearing loss are at using their visual system to fill in those gaps, taking advantage of all those nonverbal cues. I've come across people who seem to have really good spoken language communication, but then when we remove the visual condition, they just fall apart, which really drives home this idea that they're using their visual system a lot to make sense of what's going on. Yeah.
So say a person gets a cochlear implant. Can you speak more about the audiologist role like after that?
Yeah, good question. So the question was, I speak more about what happens in the audiology office after a person gets implanted. The implant surgery is done, and then the person waits about 2 to 3 weeks before they come into the audiologist's office to have the external piece fitted to their ear. And the reason we wait is because there's a lot of swelling. And the only way that the external piece stays on is by magnetic attraction. So if there's too much swelling, then the external piece will just fall off. So once the swelling has gone down, they come into the office. We make sure that it stays on their head with enough retention that it's not going to fall off from simple walking or even jogging. They should be able to do a light jog and it just stay in place. The audiologist then sets the minimum amount of current needed to get the person to hear. So what I mean is, if we put in a little bit of electricity, it may be too little to make those neurons fire, and so they're not hearing anything. So we raise the current up and take it up and up until they say, oh yeah, I can hear that now. And what they're typically hearing is like a beeping sound. Beep, beep, beep. When they can hear it, we stop. We then make those beeps get louder and louder to the point where they say, okay, that's loud enough. I wouldn't want it any louder. And so what you've done there is you've effectively created this dynamic range between the threshold of hearing and the upper limit of hearing, and then all the sounds that come in through the processor are mapped into that dynamic range. You do that for every single contact. So there's 22 contacts in one of the devices and 12 in another and 16 in the other. So you can imagine you have to do a lot of work to create that dynamic range on every single contact. In young children, we typically put through current that gets loud enough that we can generate an electrophysiological response. So we can record a waveform that deflects when there's enough neural firing. And we use those responses to guide where we're setting our results. Because obviously a 12-month-old can't tell you, oh yeah, I hear it now, and oh yeah, that's too loud. So you have to use objective measures to set those responses. Good question. Yeah?
When a cochlear implant is implanted like in a young child, does that have to be updated as they grow older, like as they're growing at all?
Yeah, another good question. Gosh, you guys are sharp. So the question was, does the implant have to be updated? There's two sides to this response. One is that we've only been doing implants for 30 years. So we expect that the implant, the internal implant, should last the child's lifetime, but truly we don't have 100 years worth of data to know that a child implanted now will be able to use that device when they're 90. So if a parent were coming in today and asking about, will this have to be replaced at some time, I would be really cautious and tell them to likely expect that at some point in your child's life, they'll want to have it replaced. But truly, we don't have enough data to know that. The external piece gets updated every 3 to 5 years. You've seen the changes in the external processors. They went from really big to really small. And those changes happen every few years. When those changes happen, it can always be upgraded no matter what internal piece they have. So people who were implanted 20 years ago can still use the most current external pieces. Yeah. Yes?
So I know that cochlear implants are really like a huge controversy in the deaf community. How do you go about like trying to convince somebody who is like really strong in their opinions about not getting a cochlear implant? Like
right.
The benefits would actually like, help them. Like how do you go about that situation?
Yeah. So the question was about the deaf community and the debate between the deaf community and the hearing community on cochlear implants. I would say that the debate is not very strong these days. The debate used to be really strong, wherein the capital D deaf community would accuse the hearing community of committing cultural genocide, of implanting young deaf children, and by therefore removing the next generation of congenitally deafened manual communicating adults. And they were right, because this is somewhat eradicating deafness. But my response is that parents of children who are deaf, who don't know sign language, need to have a language system with their child. And if they choose spoken language, then I support that 100%. If that same family thinks, you know what, I don't want to implant my child, I want my child to stay deaf and use manual form of communication like sign language, that is also fine, and that is perfect for that family. But every family should be given the choice whether or not they want to use spoken language or manual communication. My impression is that most families with deaf children want their child to be able to hear them, and so they choose cochlear implants. There's definitely geographic influences. So in parts of the country where the deaf community is very strong, most of those deaf children stay deaf. And in other places where the deaf community is not as strong and there's more of an influence of cochlear implants, you see a higher rate of children being implanted. For adults who are deaf, adults who have never heard anything, a cochlear implant is not a good idea. So if somebody who is deaf and 18 years of age came into our office and said, I want to get a cochlear implant, I would say no. It's not a good idea. You will never be able to understand speech through that device. It's an invasive surgery that you don't want to have to take the risks of for very little, if any, benefit at all. It's a great technology for the right people, for the people that fit those criteria, and for the families who choose that form of communication. Hope that helps. Other questions? Sir?
Like an older adult experiences severe profound hearing loss, do you see like a pattern of how their speech decreases? Like if they can't hear themselves, does their speech decrease over time?
Mm-hmm.
Or does it stay consistently?
Yeah, so if an older adult loses their hearing, what happens to their speech production? Is that correct? So people who are normal hearing and lose their hearing later in life have a greater chance of kind of maintaining their own productions. But eventually you'll start to hear some changes. So you'll start to hear a rise in their own productions. They may start to sound louder than their peers. You may also start to notice that they lose their S sounds because they can no longer hear themselves producing it. And they may also become more nasalized. People become more nasal because you can't hear the rise and the fall of the velum in the back of your throat. And so people with a lot of hearing loss often become quite hypernasalized. Yeah. Okay, well, thank you very much for your attention. And if you have other questions, come find me.